stage 4 cancer, but being that it is the month of October, obviously we want to talk more about breast cancer than any of the other tumors, but any diagnosis is welcome. Any question about any diagnosis is welcome. Breast cancer is a major problem around the world, and that's why there's so much research about it. And the prognosis of breast cancer patients has improved tremendously in the last few years due to many new advancements in the treatment of breast cancer. At our hospital is the #1 diagnosis where we treat the most patients. And fortunately, it's also in the area where we have our best results. In a prospective clinical trial that we did with stage 4 breast cancer patients, 50% of our patients are alive after 5 years. The 5-year survival rate is 50%, close to 50%, whereas with the conventional is less than 20%. But those are patients that come to us after chemotherapy, radiation, surgery, hormone therapy, any of the new targeted therapies have failed. So we get very complicated patients, and in spite of that, our results are very, very good, 50% 5-year survival rate. Now, when patients come to us as a first resort version to treatment, our 5-year survival rate is 75%. So it makes a big difference when a patient chooses in breast cancer our treatment as the first choice. So we're very happy about that. Overall, stage 4 cancer patients that come to us come in that condition where they have been treated by many lines of chemotherapy before. And again, in spite of that, we have been able to help a large percentage. Obviously, it changes dramatically depending on the diagnosis, but I can tell you that our treatment has been quite successful. And so we've had a lot of experience in the last 60 years treating all kinds of patients with stage 4 malignancies. So I think that we're ready for some questions, and Gaston is going to manage those questions for us, and then Dr. Ceceña and I will dwell with these questions as best as possible.
Thank you so much, Dr. Contreras. We're gonna start with some pre-submitted questions. We had over about 300 questions pre-submitted, so we have a lot to get to today. And I just wanna thank you all for joining us today. And just before we begin, we wanna say hi to Linda Brown from Lynchburg, Virginia. Hi to Andrew from Florida. And Maria Eugenia from Miami, and Diana from Michigan, Alan from Alabama, Dana from Loomis, California. This is great. This is great. So we're going to begin with a question from Andrew Lassick from Cape Coral, Florida. And the question is, can you cure stage 4 prostate cancer that has metastasized to the spine?
Now, in stage 4 cancers, the word cure is seldomly used, but it is possible because we've seen many, many miracles. But generally, what we are able to do in stage 4 cancer patients is to prolong their life, sometimes indefinitely, and in many cases without tumor activity. When we talk about 5-year survival rates, we're talking about a patient that after 5 years is still alive with good quality of life, in spite of the fact that that patient may still have tumor activity, but in a stable condition, meaning that we actually were able to convert a terminal disease into a chronic ailment. Some patients, though, will be without any evidence of disease at that time. And so the word cure nowadays, I think legally and semantically, is not acceptable because of so many liabilities. And so we are using now the term with no evidence of disease in order to avoid legal problems. But I understand your question very, very, very well. And yes, it is possible for a stage 4 prostatic cancer patient with metastasis to the bones to survive that disease. Now, Dr. Ceceña has been with us for 35 years. He has a lot of experience in all kinds of malignancies, but again, prostate cancer and breast cancer are the patients that we see the most. And so I would like you to expand a little bit on the patient with bone metastasis from prostate and how effective we've been through the years.
I would add to that the fact that our treatment has been successful in bridging many of our patients. A common situation is that sometimes a patient will come to the Oasis simply because they are not offered any further therapeutic options locally. A lot of the times they'll be given a dire prognosis, or a dire short-term prognosis, and they might want to come to the hospital to continue the fight for their life. And an interesting phenomenon happens over the years, has happened, is that we've been able to bridge our patients who, at the time that they were here, nothing of value, therapeutic value, was available to them. And as we sustained their life through controlling the disease, managing the disease, we brought them to a point a year or 2 or 3 later in which new drugs are available, in which new therapeutic options are available. And that, over the years, that has happened many times. So that's why, we keeping up the hope, keeping up the expectancy, even if you're not being cured, there's plenty of advances in oncology that do not represent the old cytotoxic chemotherapy, the old poisons. Nowadays, there are some useful drugs that are different from that, and they're coming up very frequently, and that's the way we've been able to help a good number of our patients who might be in the worst case scenario setting, so to speak.
And he's mainly talking about the targeted therapies that are being developed, because more and more we're able to target those genes that mutate, that produce certain proteins that benefit tumors. And so the more of those proteins that you target and neutralize or stop the production, the better the patient is going to do.
Great questions, great questions. We're gonna go with a live question from Sue. What are your thoughts on immune therapy like Opdivo or Stivarga?
I think that the advent of new targeted immune therapies is a wonderful thing for cancer patients. For decades and decades, the aim was just to destroy the tumor with external means. And we have been working with the immune system and for the immune system of our patients for many, many years, because we believe that the biggest asset that a patient has against their tumors is their own immune system, which has failed, and that's why the patient developed cancer to begin with. So if we improve the immune system, the possibilities of the patient surviving longer and better are much better. So the advent of these targeted immune therapies has been a breath of fresh air for oncologists and obviously for patients, because now we have tools that are not so aggressive, that are not so devastating for the patient. They may have some side effects, but much less than chemotherapy, with much better results. So we are very happy to use those elements when possible in combination with our therapies. And I say when possible because they are extremely expensive. Most of these therapies, each one of them is about $10,000 every 3 weeks. And so virtually only patients that have very good insurance are eligible for these measures because they're so expensive. But they're very, very welcome. We're very happy that immune therapies are being now developed in the orthodox research world.
That's great. That's great. How about a
I
question
think
for
Dr.
Oh, yeah, go ahead.
As we view it, the key to beating cancer is to bunch up against it, is to do many elements together, working together for each other and with each other. As good as these new drugs are, such as Opdivo, which is an excellent drug, Stivarga not so much, but Opdivo is an excellent drug when well applied. Still, cancer is a very tough customer, and it's like a star player, which usually deserves double teaming or triple teaming. You don't do one-on-one on a star player. So that's where we feel that the best possibilities to obtain and maintain long-term results is when you're doing a combination therapy. That's what we love to do, a two-front attack against cancer when using, say, for example, Opdivo, which is a checkpoint inhibitor on the one side, and the Oasis therapy on the other side. You're attacking cancer on two fronts, and that enhances the likelihood that you're going to obtain good results and maintain good results over the long term.
Perfect, perfect. Thank you so much, Dr. Ceceña. That was masterful. Let me see, Gloria Blaylock. Do you only treat stage 4? Do you treat endometriosis stage 2?
Yes, we treat cancers in all stages. Most of the patients come to us in stage 4 because usually patients seek for conventional therapy to begin with. There are some very informed patients or patients that had experience with family members before treated with very harsh chemotherapy or massive surgeries or very high dose radiation therapy, that they don't want to know anything about that, and they seek alternatives for earlier stages. But definitely, we treat patients in all stages, and obviously, the lesser the stage, the higher the success. So stage 1, in most cases, is curable, and the best therapy for most cases of stage 1 continues to be surgery. But thank God, the surgeries now have become a lot less aggressive than what they were a decade or 2 decades ago. So very conservative surgeries nowadays are very effective in treating stage 1 and 2 cancers. But yes, we do treat these tumors in early stages. And in most cases, surgery is going to be the best option for a patient, especially with an endometrial carcinoma.
Endometriosis is not a cancer, is not a malignancy. So maybe I heard incorrectly, but
Endometriosis stage 2.
yeah.
That probably was miswritten.
Probably mean
Okay.
endometrial
Endometrial.
carcinoma.
Yeah.
Grade
Okay.
2. Mhm.
Perfect. We're gonna go with a live question from Barbara. Can you help me? I have pancreatic cancer that has spread to the liver, but I feel well, just very tired. My faith in God keeps me going, and my family gives me the fire in my belly to keep wanting to live and see my 7-year-old son grow up.
Definitely. Cancer of the pancreas is very aggressive. And when there are liver metastases, chemotherapy is virtually useless, and it will only deteriorate your quality of life. Our treatment would be a much better option for you and would give you much more hope. We've seen many, many miracles in young patients like you, and I think that you would be a very good candidate for our therapy.
Thank you, thank you. Dr. Ceceña, anything? you
Oh,
wanna
that's what
add,
we
or-
call the situation that you are in,
Barbara.
Barbara. That's what we call a no-brainer. Why do we? Because there have been very good advances in certain cancers with the newer drugs. Unfortunately, that's not true presently for pancreatic cancer. And chemotherapy is still the mainstay of therapy. And, we feel that chemotherapy is a very bad option, and alternative therapy, this is the type of situation that's tailor-made for what we do around here. So we would strongly have you look into it.
Perfect, perfect. And Dr. Ceceña is one of our doctors that has the most experience here at Oasis. It's been around for 32
30 years,
years.
32 years.
Every 2 years.
Just a
And
little under Dr. Contreras.
Dr. Contreras has been here about 40 years,
40,
Dr.
yeah.
Contreras, surgical oncologist. He still sees every patient and he does do all the surgeries for cancer patients. And the great thing about Dr. Ceceña is that he's been here such a long time and he runs our follow-up department. So when you're at Oasis, you get treated by Dr. Contreras, and when you're a follow-up patient, once you go home, you are given a follow-up by department that you can talk to Dr. Ceceña at any time for any questions you might have.
We don't cut you loose.
We don't cut you loose. We don't cut you loose, which is great. We're gonna carry on with Raja. Hi, my dear doctors. XOXO, thank you, thank you. I would like to know how long I'm supposed to keep taking Perjeta and Herceptin if my PET scan results show no metastasis, because I've been told to keep it about 10 years. Why 10 years?
Well, that's the conventional way of looking at things. We believe that once a patient is in remission, we can pause, because at any time we could restart the HER2 inhibitors. And if you had very good results and you are now in remission, the reason why the conventional doctors offer you to continue with it is because the possibility of recurrence is very high. But if you combine it with a therapy like ours, we can protect you with our therapy so that you do not have to continue with the HER2 inhibitors. And we've been very successful in doing that. So we do not continue with therapies like that for very long periods. When they are very effective, we're able to stop them and continue with our therapies very, very effectively.
The better the response that you've had with Herceptin Perjeta, the more likely that you can maintain your gains the long term if you take a Herceptin Perjeta holiday. You don't want to be premature about it, especially based on your history. But once it's clear that you benefited from those drugs, then you can maintain your gains through naturopathic therapies, which is what we would be doing for you.
Perfect, perfect. We're gonna go with another question. Anonymous, but we'll ask it anyways. I know you treat all stages of cancer, but have you had any case of stage 4? That's a big word.
Cholangiocarcinoma. Yes, fortunately, these are not very common tumors. They're very aggressive, but they're similar to pancreatic cancer, probably less aggressive than pancreatic cancer, and we have been quite successful with them. That's another one of the no-brainers where chemotherapy really has nothing to offer, and our therapy would be a much better option.
Dr. Ceceña, want to add anything?
Well, tough cancers are, at the Oasis of Hope, tough cancers are on paper. Because on paper, you could have the worst diagnosis. In practice, you could have a very responsive cancer. That's why a therapeutic trial, such as the Oasis of Hope treatment, is a very valid effort, because again, some cancers which have the worst reputations can have a very good response to what we do. So your prognosis is not based on what you have or how bad it is. At the Oasis of Hope, your prognosis is based on how you respond to therapy. We have a strong therapy which can address some of the toughest cancers around.
Amazing, amazing. Let's continue on with Maria Eugenia. How would you treat stage 4 breast cancer that metastasized to the lungs?
Well, breast cancer is a family of tumors, so we would need to know what type exactly you have in order for me to tell you exactly what we would do. But let me give you the basis for this. We have a part of the therapy that is a very basic, common therapy for all cancers. Why? Because although cancer is a genetic disease, and not genetic in the sense that it's hereditary, but genetic because it arises from mutations, from DNA mutations. These mutations are very wide, and there are many of them, and so it's very difficult to treat a patient on that basis. But all cancers have common denominating metabolic factors. So all cancers are hypoxic, be it cancer of the breast, cancer of the colon, with metastases or without metastases, they're all hypoxic.
That means low oxygen environment, by the way. Yeah.
Thank you.
Mhm.
So they hate oxygen, and tumors protect themselves from oxygen physically and chemically. Secondly, because they are low in oxygen, they metabolize sugar very poorly. And so they need a lot of sugar to survive. Again, all cancers have that. Because of this poor metabolism, all cancers have a low pH. They're acidic. And so there are ways to manipulate the acidity of cancers and so on and so forth. So there are a few metabolic impacts that are manageable and that we do for all of our patients. Then, depending on the type of tumor, if in cancer of the breast, if the tumor is hormone dependent or not, we may use hormone blocking agents. That would be another part depending on the type of tumor. But then we have a very personalized part of the therapy where we design and develop a vaccine that is very specific for that patient and very specific for that patient's tumor. And so with this combination of therapies in breast cancer, we have been very successful. And as I mentioned at the beginning of our chat, is where we have very, very good results, our best results as far as 5-year survival rates.
It's important to for our prospective patients to understand that at the Oasis of Hope, we're not divorced from Orthodox practice. We're only divorced from it where we know it doesn't work. Where we know it works, we will combine it. Remember, beating cancer is a function of bunching up against it. The more elements together which are working together for each other and with each other, the more likely you're going to succeed. And so if there are elements of therapy that are within the orthodox realm, such as hormone blockers, such as HER2 inhibitors, etc., we won't exclude them simply because they're not naturopathic. We will make them part of an overall treatment approach and an integrative approach, and that gives you the best chance to beat cancer. So knowing exactly what the features of the disease is very important, as we always determine that.
And for instance, in this case where there are metastases to the vertebrae, correct? Spine?
To the
Lungs.
Where was the question?
Maria Eugenia.
Maria Eugenia, huh?
Well, if there are, for instance, bone metastases, and these are very painful, or
To the lungs.
they have the possibility of a fracture, radiation therapy in a very low dosage can be very effective in controlling pain and in hardening the bones. In your case, where there are lung metastases, depending on whether the tumor is hormone dependent or not, we will use hormone blocking agents. But if it's not, we may use a low-dose chemotherapy like capecitabine very effectively. So the adjustment, so there are some basic parts of the therapy that are given to everybody, but then depending on the specific characteristics of a patient's tumor, we will adjust our therapy and complement our therapy with either more natural elements or conventional elements that have proven to be effective and not that do not or will not deteriorate the quality of life of the patient.
Perfect. Yeah, at Oasis, I've been working here for about 17 years now. I'm half you guys.
Yeah.
I'm half you guys. So I've seen the evolution of treatments. I mean, labes are still one of the elements that we use, but I've seen how we integrate newer protocols that we see that actually work into the protocol. And the great thing about Oasis is that we test it out. We test it out with the actual patients, and we keep what works when we separate what doesn't work. And that's one of the things that I love about working at Oasis, is that the response of the therapeutic effect is key here, not just adding treatments to the actual protocol. So I just wanted to talk about that. Wendy, are there better results from anastrozole? Is there a more natural approach that mimics the effect of the drug?
Well, in hormone-dependent tumors, we have to use hormone-blocking agents, and that is not a natural thing. And so we want to bring the estrogen levels as close to zero as possible because the tumors depend on the internal estrogen. And so there are no natural elements, unfortunately, that will do that. So for hormone-blocking agents, we have to use the medications that were designed for that. They're called chemical castrating agents because the aim is to bring down the estrogen level as much as possible. Natural elements that impact hormonal balance in women, that's actually what they do. They will just balance the imbalance or equilibrate whatever has lost its balance. And so they're not ideal for the treatment of a patient's tumor that is hormone dependent.
A hormone blocker such as anastrozole is a treatment in itself. It can handle cancer, but we don't want to put cancer or anastrozole on a one-on-one situation against cancer. That's why if you surround cancer with multiple elements working together, your chances of of doing well are much better. So, as Dr. Contreras mentioned, that there's nothing in nature that works like a hormone blocker. In this case, not doing a hormone blocker, you can do it and you can get away with it, but it's not doing your strongest effort.
Great, great. Moving along, and thank you for your questions. We have a lot of questions to get to, so we're going to try to get to them all. We're just focusing on the live questions because these are really good. Alan, our son Michael is there now and battling osteosarcoma. We were wondering about IPT therapy.
Well, he's doing quite well. He's tolerating the therapy. He's a very tough young man, and we believe that the therapy as is very good for him. We're using IPT in him in preparation for the dendritic cell vaccine because when we use certain elements of chemotherapy in very low dosages, we're able to deregulate the immune system and allow the immune system to move forward and act more aggressively. So in that sense, he will receive IPT. But IPT therapy that is widely known for many tumors has not proven to be very effective in advanced cancers and much less in sarcomas. And that's why we do not recommend that therapy for Michael.
Well, we did our own trials with IPT, and the results that we got over extensive experimentation were never better than what we're getting right now. So we feel very positive that the therapy that he's doing, as tough a customer as sarcoma is, the rationale is we've done it before, we can do it again.
Sounds perfect. So Tiffany, it's a long question. Tiffany Cutler. I had stage 1, grade 2 invasive ductal carcinoma, estrogen driven. I had surgery in July. Margins are clear and cancer free. Bone density is great. Now the preventative treatment they want to do is 16 treatments of radiation and 5 years of anastrozole. From what I've researched, radiation is carcinogenic, cause more damage to the body and the side effects of anastrozole, so many side effects. I don't want to do either.
Depending on your age, I'm assuming that they're giving you anastrozole because you are not menstruating anymore. So the possibilities of cure in your case in stage 1, just with surgery, is higher than 80% if you would do nothing else. So the 18 to 20% or 15 to 20% risk of this tumor coming back is being addressed by the hormone blocking agent and the radiation therapy. Now, if you want to avoid radiation, our treatment would be much more effective than radiation to reduce that risk. Depending on how strongly estrogen dependent your tumor is, I would strongly recommend that you consider taking anastrozole at least for a few years. It's usually well tolerated, and the possibility of reducing that 15 to 20% with a combination therapy, our therapy, and anastrozole is very good. So you would be almost certain that this tumor is not going to come back.
Consider also, since you may consider yourself cured, consider also the fact that overkill with radiation can be very adverse to you, whereas overkill with something like Oasis therapy will not be adverse to you, will not open the door for a cancer. Some cancers are very, very tricky. They may have early escape, and anything that makes you very sick, such as if you had a bad reaction to radiation therapy, then that might actually open the door for cancer to come back, where, radiation will not protect you outside of the radiated area, whereas naturopathic therapy, systemic therapy such as we do, will protect you at the site of the origin and will protect you against disease spread, either if it occurred very early and microscopic and undetectable, or something that comes after a bad reaction to radiation therapy. Hormone blocking is an excellent second front against cancer, and again, it's very advisable that you consider it. And you have choices because you may consider yourself up to likely 80% cured. So, what you have to do is consider what overkill measure, what safety measure you want to continue to apply.
Perfect. I'm gonna go with a question from Todd. How would you treat stage 4 prostate adenocarcinoma with PSMA poorly producing tumors?
PSMA poorly producing tumors.
Producing tumors.
I don't know what you mean. The PSMA usually refers to a dye that it's used on a PET scan that is very specific for prostate cancer. But we have been talking about stage 4 cancers, and in your case, what we would do is use hormone blocking agents, most likely. Then all of the elements that I mentioned that are basic to all tumors. But our main therapy in your case is going to be the use of our dendritic cell vaccine in combination with hormone therapy if you are a good candidate for it. There are some patients that are refractory or do not respond to hormone blocking agents. And for those patients, we have other elements of treatment depending on how aggressive your prostate cancer is. As we mentioned before, that there are several types of breast cancers. There's also several types of prostate cancers. And how forceful we're going to be depends on how aggressive this tumor is. And that depends on the score on your Gleason test that was done at the time of the biopsy. So the lower the score, the less aggressive we have to be. The higher, which is 10, the more aggressive we have to be, because those tumors have a very high rate of proliferation. But generally, in prostate cancer, we have excellent results in comparison to just conventional therapy for stage 4 prostate carcinomas.
Perfect. Thank you so much. We have a question from Sergio from California. Hey, Sergio. Do you treat stage 4 throat cancer? More specific, epiglottis?
Yes.
That has spread to the lungs and liver.
Yes, head and neck carcinomas are treated all together because they have the same origin, and they're difficult tumors to treat, especially when there are metastases. And again, in cases like those, conventional therapy has very little to offer. And I would encourage you to consider our therapy because I think it would be a lot more beneficial for you. It would provide you much better quality of life and hopefully many, many years of longevity.
That's another one of the situations that on paper, this is a very untreatable condition, yet we have a good history of treating head and neck cancers. They tend to be highly responsive to what we do. We prefer to treat them in earlier stages for sure, but again, your prognosis is not based on on your present status is based on responsiveness to what we do, and we expect to do well.
Perfect. Let's moving on, and thank you again for sending us your questions. These are great questions, and we want to get to all of them one by one. And I want to thank again Dr. Contreras and Dr. Ceceña for joining us tonight on this amazing webinar. And we had a quick question about follow-up from Gloria. How long do you follow the patient? We follow the patient forever, to be honest with you. We say 5 years, but nobody's keeping time here. So as long as you need advice, recommendation, or any kind of support from Oasis of Hope, you will always have it. We have about 2 to 3 people dedicated to the follow-up department, and Dr. Ceceña answers all the emails and does all the consultations on a daily basis. It takes about 5 to 7 calls a day with patients. In the follow-up department, we track the patient. We always ask the patients to send us their lab work and their PET CT scan about 3 months after the treatments. That's when we determine a lot of the therapeutic effects, positive, or if we have to modify. Can you expand on that, Dr. Contreras?
Before you leave, we actually have a schedule of calls that we are going to do, and then we also let you know when we would like for you to communicate with us, for sure. But that does not preclude you from calling at any time. We're just a phone call away because patients with malignancies have a lot of problems. Our protocol is very comprehensive, and it entails the intake of many elements, and so patients will have reactions or different reactions to them. And Dr. Ceceña is a specialist in helping all of you out there to cope with these problems so that you have the best compliance possible. The better you comply with our home therapy, the better you're going to do. And so we want to help you in being able to comply with as much as possible as the therapy is concerned. And Dr. Ceceña is a specialist in doing this.
Here again, we will never cut you loose.
Great way of putting it. How about we go with Manuel? I have multiple myeloma cancer. Can you do anything for me?
Multiple myelomas is one of those therapies where conventional therapy can really be helpful. If you are virgin to treatment, I would encourage you to first do the conventional therapy because it tends to be very effective. If you have had therapy before and that therapy has failed you, then definitely come to us. In those cases, we have been able to help patients with multiple myelomas, but multiple myelomas, even in stage 4, conventional therapy is very effective, and that is what we would recommend first.
That's one of the cancers in which we will not take a primary role in therapy. We will play a support role. We can help you maximize the likelihood that you're going to do very well, but we will not try to substitute a well-established therapy and one which has a very good record to help you. So we wouldn't, how do you say, usurp? Is that the word?
Right.
We would not usurp the function of the present standard therapy for multiple myeloma.
A caveat would be a patient that is in poor general condition, or a patient that is elderly, like us, well, like me, you're still very young, where the immune system may be compromised. And what we do in those cases is do a treatment that we call preconditioning therapy, where we actually prepare the patient for the chemotherapy or the new targeted therapies. And that has proven to be very effective. Patients will respond better and will tolerate better that therapy. For a young patient that is in very good condition, I don't think you need to do that. But we do that for a number of patients where we feel that they would need more support before they start the therapy.
A valid question would be, well, how do you know your treatment works to support our therapy? Well, we've been here so long, so we were here before the developments in multiple myeloma therapy, before it became a well-treated cancer. before the options of therapy at home were not very good. And in those situations, our treatment did well. So we know our treatment helps, but again, the advances that have been made allow us to give pass to the orthodox therapies right now, and we will limit ourselves to playing a support role.
And the other reason why we have so much experience is because there is a percentage of patients that will not respond to conventional therapy. And they come to us, and we have been very successful in helping them. It's just that percentage-wise, everything in life is risk-benefit. So if the risk is higher than the benefit, well, then let's not do the risky thing. But generally, the benefit of conventional therapy in multiple myelomas that have not been treated before is on the patient's favor. So we would treat those patients that did not respond to that therapy before, and that's why we have so much experience as well.
Perfect, perfect. Ebony, you're next. You have a couple questions. So you're asking, how fast can we start therapy? Does it remove tumors? And what is your success rate with glioblastomas? And she followed up with another question that says, does the patient have to travel to you?
Okay, glioblastoma multiforme, especially the highest grade of glioblastomas, is a very aggressive tumor. And in those cases, we generally recommend that the patient first have the tumor removed, has the tumor removed whenever possible. That's the first treatment that should be done, followed by chemoradiation, because the recurrence rate of this tumor is 100%, and generally in a very short time. So when a patient has a tumor removed and does chemoradiation, it gives us time for our treatment to work better. So we've been very successful. We have patients that are alive after many years when they have done first surgery. Sometimes it's not possible, but whenever possible, surgery, chemoradiation, and then our therapy. And so that's the way that we would recommend glioblastomas to be treated. A patient that has already had surgery and chemoradiation, those patients, they should come as soon as possible, and we will do our best to help you. And yes, you have to be here for us to treat you, especially with a glioblastoma.
To underline that point, I remember a very sad case that of a patient with a glioblastoma who had surgery, and we told him, well, you should do radiation after surgery so that it'll buy time for our therapy. And the patient said, no, I don't want to do radiation. And he came here for 3 weeks. And at the end of his stay, he was not doing very well. He went back, and by the time that he went back from here, he had already a bigger tumor than before the surgery. So that's the type of aggressive disease that GBM can present. That's why surgery, debulking the tumor, number one, radiation, killing off any cells, any seeds, then sets up the possibility of success of maintaining the gains long term.
Perfect, perfect. And let's see. Quick question, Carissa. How long does the patient usually stay at Oasis?
Generally, our patients will come for 2 weeks of therapy and a couple of days up to a week, depending on the type of vaccine that we're going to offer the patients. So generally, our patients are here between 16 and 21 days.
Perfect, perfect. And continuing on, Wendy, gracias por responder la pregunta. You're welcome, Wendy. Thank you for speaking in the language of heaven, Spanish. And you see, there's a lot of questions. Okay, Leon, great question. Do you develop vaccines for all types of cancers, or does it depend on the type of cancer? My mom has a tumor cancer in a vein that enters the liver.
The vaccine is very specific for that patient and very specific for that tumor, and it can be developed for any kind of tumor. There are no limitations for the development of the vaccine.
Perfect, perfect. And Todd, he was asking a question before about prostate-specific PSMA.
Yes.
They says prostate membrane. They are undetectable by PSMA PET scans. Gleason 5+4.
Okay, so Gleason 5+4 is a very aggressive type of cancer, and if unfortunately the PSMA was not able to detect it, most likely the typical FDG will not be able to detect it, and in those cases we can virtually only detect the bone metastases, and that is done through a bone scan, and I'm pretty sure that the PSMA was able to detect that.
Full body MRI.
Or the full body MRI is another very good option. It does not give us all the information that a PET would give us, but it would certainly give us the location of the metastases for sure. So that's another one. But yes, we do treat patients in stage 4 with Gleason 9 and 10 with success, and so I think you would be a good candidate to come for our therapy.
Thank you, thank you. Sergio Andrade from California. I remember, what is the process to start treatment with you? Very easy. Just call our 800 number. It's 1-888-500-HOPE, or you can call direct at 619-690-8450, or just go on our website. Very easy. All the numbers are there. You can fill out one of our contact forms, and one of our admissions coordinators will contact you. The great thing about Oasis is that you speak to a doctor so you can get a recommendation. We usually require that you send in your medical records, or you can talk to one of our admissions doctors. Her name is Dr. Heidi, great doctor. And then you can talk about your case and she can try to recommend treatments. But all cases are reviewed by Dr. Contreras before admission. So yeah, you just call us and you can start the process.
And the accessibility is quite easy. We are about a half an hour away from the San Diego airport. So most of our patients that come from the States or from Europe actually fly to San Diego. There's an airport here in Tijuana. There are some patients that come directly to the airport in Tijuana, especially the ones that come from Mexico or South America, so Central or South America. Some patients from Europe also have flown here to Tijuana, but the most easy access is the San Diego airport.
Yes, we've had a lot of stories. People fly in LA, they take the train down, they drive all the way down to Tijuana in a camper. We had a patient stay here for about 3 months in the Peace Band, remember?
Yes.
It was great. And yeah, so all patients that Dr. Contreras is flying to the San Diego airport, we pick them up there with our drivers pick them up there, and they bring you down to the hospital. So it's completely red carpet process. So we'll continue with treatment with a package that we've done. Okay. How long would you recommend, Angela, how long would you recommend treatment for lung adenocarcinoma in mediastinal lymph nodes?
In your case, we would recommend what we call our enhanced program, which is 2 weeks of the metabolic therapy that I mentioned before, and 1 week of for the vaccine to be applied. That would be the initial therapy. And then we evaluate, and in 3 months, we do a booster of the therapy, especially of the vaccine. And depending on the results, we will let you know if you need to come back again in 3 months or in 6 months or a year. I repeat, depending on the report, on the response.
Perfect. And Cecile Christini, I had breast cancer treated first time with surgery 8 years ago, then a lot of natural treatments back, and then back to the hospital when I had water in the lung and then metastasis in the head. Then with hormonal therapy and ribociclib for 6 months, the lesion in I think this is translated to Spanish. Yeah.
They were gone, so she had a good response.
And done radiotherapy after this. My cervical uterus was clean, but they did 1 chemo. After 1 chemo, I had a bad liver reaction. What can I do?
You would be a very good candidate for our therapy. We have treated many patients that did very well for a while and then had a recurrence. and the tumors usually come back more aggressive than originally. And that's where we have our most experience. I think that you would be a very good candidate for our protocols.
You have a responsive cancer, you know, one that allowed you 8 years of disease-free. These type of cancer, if a cancer responds to the initial therapy, it will likely remain responsive to anything else that you do against it. And you want to take it, you want to take the less aggressive route if you can, such as naturopathic therapy, possibly in combination with hormone blocking, and keep everything else in reserve, because some of the remaining elements of therapy that you're going to have as a choice can be very aggressive.
Especially if you did not tolerate the chemotherapy. I think that our protocol would be a good protocol for you.
Perfect, perfect. And Gloria is asking, is this an all-inclusive treatment program? Meaning, do we still use our outside oncologists? Great question, Gloria.
Very good question. If we can establish a team member from your side, it would be wonderful, and it's the best option possible. Many times, though, oncologists are very much against a patient doing alternatives, and if that is the case, then it's better to not irritate your doctor and just keep him so that he can help us with some medications that are expensive, and if he orders them, the insurance company will pay for them, and also for him or her to be able to prescribe for you the follow-up studies that are also expensive, like PET scans and CAT scans, so that we can determine how well you're doing. So in general, if we can keep your oncologist as a team member, that's the ideal. And if not, we'll try to irritate them the least possible so that they continue to help you whenever the conventional elements are necessary and good for you.
Our treatment is designed for self-treatment. Our treatment is designed so that you don't need your oncologist, generally speaking. All you need, and a lot of our patients are advised simply not to, you know, they're told that what your oncologist doesn't know won't hurt him. If he's already prescribed a drug which is compatible with what we do and we would want to be doing ourselves, then just you know, leave the sleeping dogs lie, so to speak, because as soon as they know that you're doing something from Mexico, that your relationship can change, you know. Sometimes you need to tell your doctor because you need a certain drug, a certain treatment. But if you are, most of our patients keep it discreet unless they have a very good working relationship with their oncologist, and fortunately some do.
Yeah, the younger the oncologist, usually the more open they are.
Perfect, perfect. Ebony, should we start planning now for him to be there immediately? Ebony, why don't you give us a call? We have our admissions coordinator at the office now. It's at 619-690-8450. That's 619-690-8450. They'll be happy to help you. Let me see. It's almost 5 o'clock here Pacific time. It just flew by, huh?
Yes.
We're gonna answer a couple more questions and let these busy doctors get back to attending our patients. Does the protein coding vaccine for mutations replace immunotherapy or work in conjunction with immunotherapy?
I don't know what a protein coding vaccine is. Do you? I have no clue what that is.
Can you repeat that?
Protein coding vaccine for mutations replace the immunotherapy.
Maybe you can expand on that, Angela, a little bit, or send us an email.
Yeah, please do, because I have no clue what you're talking about. But our immune therapy is very specific to destroy tumor cells, whether a protein coding. I'm imagining just that
some of these treatment strategies will have protein stick to a abnormal cell surface, and then become a target for attacks, and that might be what you're
That might be,
referring to.
right.
But we haven't heard it referred to in such a manner.
Okay, we have another second to last questions, I promise.
Right, great.
Second to last question. This is a good question. I did 7.5 cycles of chemo and immuno based on my recent, okay, I did 7.5 cycles of chemotherapy and immuno. And based on my recent labs and imaging, my oncologist from MD Anderson advised to stop chemo and start target therapy for my mutation IDH1, which is Tibsovo. I have an appointment with the radiation oncologist next week as well. Should I start with a treatment or seek therapy at your facility before I start with them?
Which is what this is?
He or she did not mention what type of tumor, where it is.
If you could,
I think that your case would be a good one for you to go into our website and send us reports so that we can study it thoroughly and give you an intelligent response.
Okay, Cecilia, where can I text my specific issue to Dr. Contreras in Spanish? Call us or send us an email. Go to our website, fill out one of our contact forms, or call us. Our admissions department speaks Spanish also, so don't worry. They're there now if you want to call, or you can call tomorrow starting 7 a.m. Let's see, 7 a.m. 7 Pacific time. Okay, Lisa, can you explain the process of treating metastatic ovarian peritoneal cancer?
In many cases, ovarian carcinomas, whenever possible, we will do a debulking surgery. That has proven to be very effective for patients with ovarian cancer. So that would be one of the things to consider. Then the treatment would be, as I mentioned, the elements with high-dose vitamin C, high-dose B17, ozone therapy, hyperthermia, a number of other elements that we use in order to make the cancer more susceptible to a low-dose chemo that we usually provide for these patients or administer to these patients, in the production of the very specific vaccine for that cancer. These cancers tend to be aggressive, and sometimes when they invade the peritoneum, debulking surgery is not necessarily possible, but that's more or less the process that we follow in treating patients with ovarian carcinomas.
A little historical perspective here to be encouraging to you. Years ago, we would not dare treat ovarian cancer without a standard course of chemotherapy. Our treatment was not strong enough, was not fast enough, and as you well know, ovarian cancer can gain ground to then put you in a totally different situation and make any treatment at a disadvantage. So with our present regimen, we no longer have to do standard chemotherapy regimens. So we do our standard protocol, and our results are as good or better already, because we're not doing chemo. And this is especially valuable for people who failed to chemo. But if you've already done chemotherapy, or if you haven't done chemotherapy, and for any reason you don't or can't do it, then you should have an excellent option to resort to, and that describes the Oasis of therapy very well.
Amazing. So we're gonna just finish off with 2 quick questions. I'll answer one of them, and will this webinar be posted anywhere, Todd? Yes, tomorrow it will be posted in its entirety on our Facebook page and then on our YouTube page. And also we will do little clips of answers of your questions with Dr. Contreras. And we're gonna end with a great question from Ashley Galantine. Regarding the dendritic cell vaccine, is this the same type of vaccine that cancer research centers are trialing in America? I ask because the cost is significant in America and Europe compared to Mexico's vaccine.
Yes, I'm very sure that that we're talking about the same thing. There are a number of trials in America in preparation for the approval of the vaccine. This vaccine has been approved in Mexico now for over 13 years, right? It has not yet been approved in America, although it was developed in America. I think it's been approved for pancreatic carcinoma in some centers. And the reason that it's approved in Mexico is because the FDA requires that you have safety and efficacy protocols. So efficacy is very easy to prove. The tumor reduces or not. But safety sometimes takes many years to determine if a treatment is safe or not. And Mexico approved it because it really doesn't make any sense to do safety protocols since the vaccine is prepared for one patient and will not be ever given to any other patients. So Mexico did not require the studies for safety, and that's why we've been able to use these American-developed vaccine in Mexico for many, many years, and I hope that in America soon you will have it available. I believe that the price difference is going to continue to be very important or significant, and so many patients will choose to do that therapy in Mexico. And for the second thing is that we have a lot more experience with it than in America.
Just a note on that, from the business standpoint, it's a lot more profitable to work on new drugs, which are called lymphocyte engagers, which basically do the same that dendritic cell vaccines do. But instead of doing a dendritic cell culture and injection, they're going to do a drug to engage the lymphocytic, and well, that you know, that's very profitable, and unfortunately that is the direction that some of the pharmaceutical companies are taking.
And these new drugs are going to have severe, at least significant side effects, whereas the dendritic cell vaccine, since it's produced from your own cells, the side effects are due to the preparation of the vaccine and the chemical used for the preparation of the vaccine and the immune response that your system has. And usually the typical side effects are flu-like symptoms. Rarely do we have more symptoms than that. So I believe that the best approach is the dendritic cell vaccine rather than these new drugs that are going to be very, very expensive and with a high possibility of complications.
And profit.
Well, it will be very profitable.
We'll just end on new news at Oasis, right? The newest we're continuing on with our immunotherapy laboratory, and why don't you give us a little bit of information about the newest treatments at Oasis?
There's been developments in how we prepare the vaccine. So the most typical vaccine that we're doing right now, we apply about 10 million dendritic cells in 3 dosages, so that we reduce the risk of reactions to the vaccine. With a new technology in a couple of tumors right now, we have been able to apply the 10 million in one application, so that instead of needing a whole week to apply the vaccine, we can apply it in 1 day. And so that's a big advantage. I think that by the beginning of 2025, we will have that available for all patients. So that's going to save time and money for our patients. The second thing that we will have ready next year is a protocol where we obtain many, many more cells through a process called electrophoresis. And we would be able to prepare about 6 to 10 vaccines in one blood draw instead of just one vaccine per blood draw. And so again, that's going to make the therapy more cost effective and more effective, because we will be able to vaccinate our patients in shorter time periods. Instead of every 3 months, hopefully every month, and sometimes even every 3 weeks. And the more vaccination you give, the better the results. So those are the new things that are, right at the corner. And we're very happy and enthused and excited about doing that. The long-term project that we have with vaccination is to produce CAR T cells, which have been effective, but are terribly expensive. In America, one application is about $500,000. Here in Mexico, it's going to be between $50,000 and $70,000, and so we're very excited about those prospects for the very near future.
Yes, immunotherapy is the future
Immunotherapy is
of
the
cancer
future.
treatment.
Well, right now, it's a very exciting period of
Yes.
time because we seem to have bumped into a breakthrough in regards to our technique and treatment modality. And, we had one of our patients who we did not expect to respond very well, responded dramatically. And, we did an adjustment to their vaccine based on the fact that he was a transplanted patient and that he had immune suppressive agents taking. So that's a very big handicap for any therapy, especially one based on immune stimulation. Well, his response was dramatic, and so I think we're on the verge of a breakthrough.
We're on the
Yes,
verge of a
We're
breakthrough.
putting that to the test, and we're praying that that's gonna make a big difference.
Divine strategy is what we pray for on a daily basis. God is the medical director here at
Amen.
Oasis, and everything we do, everything we modify, everything we add is for the therapeutic effect of the patient. And we're very proud to say that the immunotherapy lab that we developed about 3-4 years ago, that it's been going. We've just been seeing amazing results, and soon we'll have a webinar just on results, on before and
Yes.
afters of tumors. And the patient that Dr. Ceceña was talking about, it's dramatic results in about 3 months with the
In about 3 months,
of
the massive liver metastasis is reduced by 70% at least.
It is amazing. So I want to thank you, everybody. We had a great turnout, a lot of questions. We couldn't get to all the pre-submitted questions because there were so many, and there was a lot of live questions. So we focused on that. I want to thank Dr. Contreras, our chief
Thank
here,
you.
our medical director here at the hospital, and our director of oncology, Dr. Ceceña. There's about 72 years of cancer wisdom sitting here in front of you. And like I said, if you have any questions about our treatments or recommendations, if you want to speak to one of our doctors, please call us at 619-690-8450. That's 619-690-8450. Or please go onto our website at oasisofhope.com. You can fill out one of our medical questionnaires, and one of our admissions director will contact you as soon as possible. Thank you so much. Thank you so much. And we'll see you in about 2 weeks with a new webinar. We're going to do this on a bi-monthly basis. And maybe Dr. Ceceña will join us if he wants to. I think he enjoyed
I'll be happy to.
being here with us. And thank you so much, and have a lovely day. May God bless you and your entire family. Bye.
Thank you.
Bye.